Our next speaker is Dr. Atif Zafar. He is an assistant professor of stroke neurology at the University of New Mexico, and he and I have been spending lots of time together there. And he's also medical director of our CCM Center of Excellence at the University of New Mexico. And he's going to be speaking to us about the symptoms that come along with CCM, and then also a little bit about hypoxia sleep apnea.
Yes. Perfect. Thank you. All right. Good morning, everybody, and thanks, Connie, for inviting me for the talk. I'm excited about this topic. So, I've been managing CCM patients for the last 3.5 years while I've been at University of New Mexico. My mentor, Dr. Leslie Morrison, was really is considered one of the pioneers with Dr. Awad in the CCM arena. So I had a chance to learn a lot from her, still stay in touch with her about the disease. And obviously, our patients at UNM, we have one of the world's largest cohort of patient population. So we have a very busy clinical program. So what I'll share with you in the next few minutes is what I've learned about CCM from my patients as well as from the clinical arena, and the clinical work that we've been doing there and collaborating with other centers. So the topic sounds very simple. You guys are familiar and already know about the symptoms that are associated with CCMs and cerebral cavernous malformations. But what I would go through initially in my talk is trying to give you the perspective and the conceptual understanding of what us as clinicians are thinking when you are telling us the symptoms. And when we are making the recommendations based on your symptoms, where are we coming from, and when are we advising you to be aggressive with management, and when we shouldn't be aggressive with management. So it will be kind of a conceptual talk in the initial part, and then we'll go to the usual symptoms and what management is out there, what's the cutting edge stuff that's coming out as well. So starting from the basics, it's not a highly prevalent disease. CCM is not a highly prevalent disease, and then the presence of the sporadic form and the familial form make it even more complicated. The sporadic form, as you have already heard, is the more dominant form, and that's the more benign form, which rarely bleeds, which is typically asymptomatic, which is typically the one that is found incidentally. And then on the other end of the spectrum, the 20-25% of the cases are the familial forms, where the Cavern Omas can be multiple. They are not necessarily associated with the DVA. There are multiple lesions, as I said, and there the symptoms are much more lethal and more significant and impressive for our patients than in the sporadic form. So a lot of the talk a lot of the things that we're going to discuss today will be focused more on the familial form than the sporadic form. In the familial form, there are these three types that you also heard about, the CCM 1, 2, and 3. The CCM 1 is the most prevalent form in the world, and in New Mexico, where I practice, that's the most prevalent form as well. The CCM 2 and the CCM 3 are also there. In our group, maybe 5% or less patients have the other type of genetic mutations. So what are the symptoms that we normally associate with CCM? The most common one, and we've done this, these epidemiological studies from various angles and in different areas in Europe, in Asia, and in North America, and we have found pretty much similar numbers. So the prevalence of headache is really the highest, 60% or more, seizures ranging between 25 to 30%. And then some other things that we're learning, the spinal cord related symptoms that we have kind of dug into in the last 15, 20 years. this study was also kind of done in our center. We found that about 10 to 15% of the patients have spinal cord lesions, symptomatic or asymptomatic. And we'll talk a little bit more about how they can manifest. Cognitive complaints, which is one arena that usually is not incorporated in our usual understanding of the disease, but the more patients we see, the more we realize that these cognitive symptoms are a big chunk of what limits the lifestyle of many of our patients. And we'll talk about these cognitive symptoms that can range from simple memory issues or patients coming in with thinking they are having some early onset dementia or symptoms with like executive slowing and they're having a hard time multitasking. So we'll talk a little bit about later in the talk. And then the more severe form, which is really a small proportion of our patients end up having these, are the hemorrhages. And they vary. We've talked a little bit in our last presentation about the percentage of the risk in future. But even in that hemorrhage part, we'll talk about the symptoms and we'll talk about the concept of, as clinicians, that we're thinking there's this oozing phenomena that's much more prevalent in the Cavern Oma patients. And then there's this rupture that we talk about where the hemorrhage is pretty significant and the symptoms are very significant. So we'll go in a little bit deeper in understanding what that means for you as patients and caregivers. But really what the hemorrhage entails is patients present with focal symptoms. So wherever that lesion was, which bled, the area of the brain, that functionality goes down and the patients present with those symptoms, and they can range from weakness in the hands or facial droop, slurred speech, balance issues, double vision, all those type of symptoms, and we'll talk more about it as we move further. All right, so as I said, the initial part of the talk, and I'll try to move fast so that all of us can go to lunch in a timely way, but really what the concept I want to go with you here is first understanding what the brain looks like, and when the lesions are there, these abnormal cavernomas are there, what does it do and what is the physiological concept behind it. So this is our brain, and you can see these are our cerebral hemispheres. So this is a brain from an autopsy, so it's a real brain from a patient. So these are the two cerebral hemispheres. This is really where the deep part of the brain kind of starts, the thalami and the hippocampal areas. And then this is the back part of the brain, the cerebral hemisphere that normally takes care of our balance. And then there's this brain stem in front of it. And then I've cut the spinal cord here, but this brain stem extends down into our neck and the spinal cord. So that's how the brain looks like. So now we'll go to our next slide, and we'll try to make sense out of what happens there. So in CCM, especially the genetic type, the familial type, we have these cavernomas that start forming within the brain tissue. So there's a normal brain, and in many instances, a lot of the newborns, when they're born, they don't have cavernomas. They may have genetic mutation, but they may not have a cavernoma. And we've done enough studies that as we age, more and more cavernomas are beginning to form within the brain tissue. So what this slide is kind of talking about is these cavernomas, as they evolve, how do they anatomically look? So here we have this part where these things, ball-like things in the center, are the cavernomas. And what they are, in normal people, these are these thin capillaries that you see here, that when the artery comes to the brain, it divides into arterioles, which are small arteries, then they become capillaries, and then they become venules, which are small veins, and then they become the full veins, which drains the blood back to the heart or back to the body. So when the cavernomas are being formed, what's going on is that this capillary area, so not the arteries, not the arterioles, but the capillaries start to malfunction. So that's what the genes are asking the brain tissue to do, or the blood vessels in the brain tissue to do, is to start forming as abnormal structures. So now we have these abnormal capillaries that are malformed, they are misaligned, they are leaky, so they are more dilated and more like bigger than the normal capillaries. So what do the capillaries do? The capillaries are that part of the brain, or wherever they are in the body, where the brain tissue asks the blood cells to give them oxygen and food, and then secretes back or excretes back the molecules that it thinks is not useful for it. So those things go back to the capillaries, and then the capillaries go into the venules, and the venules go into the veins, and then that is drained out. So really, capillaries are critical structures in all parts of our body, because that is where the exchange of nutrients and the exchange of oxygenation, the exchange of food is taking place. Now, as I said, as we age, more and more of these cavernomas are being formed in our brain. And just as we looked at our previous slide, these cavernomas will start forming here in our cerebral hemispheres, will start forming in the deep part of the brain, will start forming in the cerebellum, in the brainstem, and in the spinal cord, and that is variable. And some people can have more of them in the cerebral hemisphere, some patients can have them all over, some patients can have them more so in the deep part of the brain, and that is variable, and that we don't know why that happens. And it's not unique to Cavern Oma. Pretty much all genetic syndromes present like that, especially the autosomal dominant with variable phenotype presentations, those type of genetic disease. All right, moving forward. I'll talk a little bit about this slide. So you just heard that when we are using the procedure called cerebral diagnostic angiogram, so the catheter goes up into the neck, and then a dye is injected. And as the dye is injected, the contrast flows through the carotids and into the brain arteries, and then goes through the brain arteries, through the arterioles, through the capillaries, through the venules, and through the veins, and back to the neck. This all can be grabbed in the picture form when we are doing these procedures in the cerebral angiogram within seconds. So the contrast is injected, and all this flow dynamics from the arteries to the arterioles to the capillaries and the venules and the veins can be visualized within seconds. However, when we are doing this same test in patients with CCM, the contrast is injected. We see this flow of contrast through the blood vessels normally wherever these structures are, these arteries and veins are, but we are not able to visualize a cavernoma through this test. And with this understanding, we already know the reason why we don't is because wherever these cavernomas are forming, or they are, the flow of blood is so sluggish and slow that during the time when we're taking these pictures, the blood is flowing through all the normal areas, but is not flowing through the cavernomas. So our understanding is that the flow is so sluggish that we're not seeing the contrast flow through that area during the time when we're taking pictures. So that's one concept that is very useful for us as clinicians, that unlike an aneurysm that you just heard about, where the flow is so dynamic that when it, and if it ruptures, it bleeds, and the patients have a higher morbidity and a higher mortality. Sure, sorry. A higher mortality and morbidity in those patients. In cavernomas, on the other hand, we see more disabling symptoms, more headaches, more seizures. Patients are reporting that they don't feel well, but then on the other side, when we're trying to capture those through signs, like is there a significant weakness and things like that, we're seeing a severe manifestation on the aneurysmal side, which means patients who are presenting with aneurysms have more severe symptoms than patients presenting with a cavernoma. The reason behind that is that the flow in the cavernomas is slow, and that's why it's more oozing and leakage in that area that causes symptoms rather than rupturing, which is causing more severe symptoms like we see in aneurysm. Yeah, go ahead.
Just a clarification there, is the blood flow slow? Is it slowed by the cavernoma, or is the inability to image via angiograph just due to the fact that you're looking at capillaries?
So no. So it's a good question. So it's the sluggish flow. That's why we are not able to capture it. And in some instances, we believe that those cavernomas have pretty much occluded or there's no flow at all. But it's more flow-related concept here that the reason why I wanted to share this. On the other hand, when we are doing MRIs, we are capturing these lesions because MRI is more of an anatomical picture rather than a flow dynamic picture. So it's giving us, and we can measure even the smallest of the cavernomas and find it on an MRI with those specific sequences. All right, so with this concept, we'll move a little bit forward to our next slide. And here what I want to talk about is you see these cavernomas in the brain tissue in different parts of the brain. And the interesting part is that when we take these cavernomas out, when neurosurgeons take these cavernomas out, and we look at it under the microscope, these are truly cavernomas. We are not seeing neurons and brain cells intermingled within these cavernomas as such. So obviously, it's a brain tissue. There are capillaries, and in the capillaries, they're adjacent to the brain tissues, so there will be brain tissue. But the concept is that the cavernoma abnormality is primarily a capillary or a blood vessel-related abnormality. So if we are seeing lesions growing bigger, and your physicians are telling you that your cavernomas are more or they are bigger, what it entails or what it means is that these cavernomas are getting bigger, but the brain tissue in that area is still normal. So it's not really an abnormality of the brain tissue. It's the abnormality of the blood vessels or the cavernomas. So this slide kind of shows, this MRI with an SWI sequence, and you see multiple black dots. These are all cavernomas. We already talked about it, that if we look at it in a microscope, these will be abnormal capillaries that we just talked about. And here we're kind of looking at those blood flowing in those capillaries. Sometimes because of the sluggish flow, it can be a clot in those capillaries. So it's kind of a mixture of thrombus and slow blood flow in these abnormal cavernomas. All right, so with this, we'll start talking about the symptoms. So the most common one, as we just talked about, headache. 60% or more patients have headaches as the most common symptom. They can range from migraines, and then migraines have these criteria, whether they're migraines with aura or migraines without aura. Patients with CCM can have tension headaches, and then patients can have headaches that are just related to CCM located in the area where the cavernoma was oozing or leaking or the bigger cavernoma was. So these are the three more common types of headaches that we hear about from our patients. And the management is based on what type of cavernoma, what type of headache it is. The majority of the patients have what we call the migraine headaches. So these are the headaches that have nausea or patients are complaining of nausea or vomiting, photophobia, phonophobia, which means they feel like light bothers them, sound bothers them. Sometimes they get worse with activity. And we're still trying to learn whether these patients have migraines, and because of the presence of cavernoma, those migraines are becoming worse or getting worse, or it's just a primarily CCM-related phenomenon, and we don't know the answer to that. Right now, most commonly as neurologists, we feel like a lot of these patients have migraines, and because of the cavernomas, we're having more symptoms and worse migraines than in other patients. And then there are these other types of headaches, like tension headaches, where patients report that the headache is in the back of the head, it's throbbing and tight feeling, kind of radiates to the neck as well. And then, as I said, the headaches secondary to the CCM are typically related with cavernomas in that part of the skull where they're pointing out where the headache is. Now, a lot of patients with CCM, especially the familial CCM, feel like, I have headache, I want to be on medications, I'm otherwise doing fine. Why do I even need to be on medications? Because they feel like, then it reminds them that we have CCM but the reason why I gave you this whole conceptual theory before, talking about the symptoms was that really a lot of times when a cavernoma is oozing or leaking, the headache gets worse. So if I have CCM and I'm living with cavernomas, and I am one of those 60% of patients with headaches, and I feel like, okay, I can live with the headache, I can work, I can do all my things, but then the headaches can get worse some days based on my stress level, based on how exhausted I am, and then the same thing can happen when my cavernoma is oozing or leaking. And if I'm not staying on top of my headaches, then I won't be able to say when is this cavernoma leaking and when it's not. So as clinicians, our suggestion or recommendation is that if you feel like your cavernomas are disabling, causing headaches, to the point that it's affecting you, you're affecting your social life, and it's making you think, oh yeah, I have headache and I should take a Tylenol today, then it's reasonable, and our suggestion is it's better to be on a treatment regimen so that if you have a bad headache, then we can distinguish it or differentiate it from your usual day-to-day life.
Can I ask a question?
Sure.
My neurologist, she refuses to give me a prescription for an NSAID, or she doesn't want me to take the lead for that treatment because I have inflammation. She wants me to take an opioid instead. How do you feel about that?
Sure. So if you don't mind, what I'll do is at the end of the talk, I will answer this question as such. Because, see, that's what Angioma Alliance is doing here as well. There are neurologists, leave alone primary care physicians, who don't understand how to manage this as well. So that's why we are also excited in giving these talks and going to conferences to kind of improve awareness and improve the system of care. So I don't agree with how you're being managed, but I don't want to go in the controversy now. So at the end of the talk, I will try to answer that question in a more politically correct way. So going back to it, the headache management is kind of critical in CCM patients, more so in patients without CCM who have migraines or who have headaches. There are various theories on why these headaches are happening, and I don't want to go into detail, but I want to talk about two quick theories. One is what we call the depolarization concept, where the idea is that there's this electrical activity starting out in the brain, maybe triggered by a cavernoma that's in that area, and then it expands all over to the brain and in the form of pain or ache or headache. The other theory is the blood vessel theory, where the idea is that the blood vessels are kind of vasodilating or constricting, and the meninges, which are the coverings on the brain, kind of don't like that change of caliber of the blood vessels, and they trigger the headache. But really, that's why these are the two different types of medication classes, the anti-seizure medication class and the blood vessel, like the drugs like propranolol or verapamil that are used in migraines or in headache patients. But these are the two theories. We're not 100% sure how the migraine phenomena or the headache phenomena in general works. The last line talks about more cavernoma lesion burden associated with more headaches. We have debated about this for the last 15 years. We just looked at our latest data that we're writing up for a paper in the next 1 month, and for the first time, we did find an idea or some numbers that are correlating that if we have a larger lesion burden, then that does correlate statistically significant with a more prevalence of headache. And we'll be presenting that very soon. But prior to that, I was telling my patients, I have a few patients who have 4 Cavern Omas and few patients who have 500 Cavern Omas in their brain. And I feel like I can't predict which patient will have more symptoms or more headaches. But now with this result in our study, our BBMC study, we feel like we'll be able to tell our patients that more lesions will correlate with more headaches. Quickly talking about the management, there are these 10 to 12 preventive medications that do not do anything with regards to aborting a headache, but they are helpful in preventing the headaches from happening. So that's a totally different class of drugs, and they are preventive drugs. They are called prophylactic medications, and they range from many antiepileptics and the blood vessel manipulators like verapamil and propranolol to certain other drugs as well. And we're doing different studies on our group of CCM patients to see which one's the best. Right now, we feel like verapamil, propranolol, and nortriptyline are our 3 favorite drugs in CCM patients that help prevent the migraines from happening frequently. And then there's this abortive class where if I'm having a headache, how will I break it? I have to go for camping with family or go to work. Today's a busy day. And that's where the NSAIDs or Tylenols or, I don't like it, but opioids can be helpful in aborting them. But typically we recommend Tylenol in those cases because of this controversial use of, or the controversy behind the use of Aleve or NSAID type of drugs. But using them every now and then is totally fine based on our recent experiences. It's just that we don't want our patients to take them on a daily basis because then they can start working like aspirin and make it a blood thinner. There's some recent data that talks about even aspirin being maybe useful in patients with Cavern Omas, but this is very early and we're not going to make that recommendation as of now, but we're doing some studies to see if that is really the case. And the reason why this interest came in is because there's strong data now that using a baby aspirin every day may help patients with aneurysms, which was an unbelievable concept when it came out 5 years ago. But now there's a clinical trial going on where patients are taking aspirin when they have an aneurysm in their brain, and the idea is that it's helping prevent the inflammation and rupture of the aneurysm. So we're kind of replicating the same phenomena to see if it will be applicable in Cavern Omas. We have a large cohort in New Mexico where we are giving Botox to patients with CCM, and Botox is also comes under the preventive category. Yesterday we had a poster at the conference where one patient with CCM who was getting Botox ended up having a oozing or oozing of a Cavern Oma. So they presented that just so that if all of us keep that in mind. I have at least 40 or 50 patients who have CCM and who've been in our Botox program for the last couple of years. And 60% of them are doing phenomenal. We haven't had even a single oozing or bleed in our group. But before I started offering Botox in New Mexico, most of the physicians were not offering Botox to our CCM patients because we didn't know whether it's safe enough or not. Yes?
I'm sorry to interrupt, but is the Botox, was that offered because they were comorbid with
Headaches.
migraine to begin
Yes,
with?
yes.
It wasn't just CCM?
Not at all.
without migraine?
Not at all. So I'm just talking about the headaches here, headaches in CCM patients, so you're right. So and then there are other things out there. There's a new drug that just came out in the last 1 year that we have already started trying. We have 4 patients on it, and we'll keep on sharing all that information with you. So I'll move faster because Connie is like pointing out that I have another few minutes left. So seizures is the second most common symptom. About 30% of patients have it. Can be focal, primarily generalized, can be a mix of these things. Is sometimes an issue with many of the CCM patients. In our experience, Keppra and Vimpat combination has been the safest and the most effective, and we use it a lot, and we have very high complexity of patients, and they have responded to this combination really well. Recently, in the last 1 year, I've started VNS and RNS, which are these surgical procedures that neurosurgeons help us with, and we have only 6 or 7 patients with CCM who have refractory epilepsy who are on these, and they're doing reasonably well, and we'll keep everybody updated on how those patients are doing in the CCM arena. Spine-related symptoms, a new entity, but patients can have any, from numbness and tingling in their extremities to weakness. Rarely they have bowel or bladder symptoms, but those can be associated. Currently, we are not screening all our patients, but if CCM patients have spinal cord symptoms like weakness, numbness, type of things in their arms or legs, then we do get an MRI with a specific sequence to pick up these lesions. A very small number of patients end up needing intervention surgery in the spinal cord. Mostly they are managed conservatively. Cognitive and memory issues, we're doing a lot of studies on this at UNM as well, and that's where we're kind of strong proponents that all our trials and studies that are going to be done, we need to have this component as an outcome measure in there because memory, cognition, aptitude, multitasking. I have a CEO of a bank, a very high functioning person who's still functioning but does report some multitasking related issues in the high stressful situations that we have confirmed through our testing that is related to the multiple Cavern Omas. So there are those things that a lot of studies are happening, and when patients report those, then we kind of counsel them along with the neurocognitive specialist on how to overcome those, sometimes improving on the cognitive strategies and cognitive therapies help in recovering from those cognitive complaints. Intracranial hemorrhage, that's the most debilitating of all the symptoms. And really, oozing versus rupture is really what defines how aggressive the surgical intervention needs to be. And the location obviously plays a role. Every time we have a patient with oozing or rupture, we are recruiting them in clinical studies that Dr. Awad is leading. And then we refer them for the statin trial, the EPOC trial that's happening right now. And based on the results of the functional MRI, we decide whether the patients will be surgical candidates or not, because there's no doubt after the first bleed, the risk of future bleed goes up. Most of the patients with oozing will have, or bleeding will have, more headaches. If they have a history of seizures, the seizures may get worse. And then the most common is the focal neurological symptom, which we deal just like with every other stroke: weakness, numbness, slurred speech, facial droop, double vision, balance issues, language and speech symptoms. Be fast is the term that's used to educate population. So does hypertension, diabetes, hyperlipidemia has any role? So if I have those and I have CCM, will that play a role? Well, we just presented something yesterday where we are continuing to look at it in detail, and we didn't find any correlation with that. And that's why I gave you the concept that if my blood pressure is high, maybe another blood vessel will rupture, but not the Cavern Oma typically, because that's the one where the blood flow is the slowest. So none of these things so far of what we know is playing a role in how the Cavern Omas are going to behave. Can sleep apnea impact patients with CCM? I'm pretty much wrapping it up here. In our experience, yes, it does. That's kind of one of the most exciting things that our group is doing right now. We have 7 or 8 patients who have already got the CPAP, and they're doing phenomenally well. A few of them were pretty much disabled before we put them on CPAP. But really, the idea is that a lot of the symptoms related with sleep apnea are the symptoms that our CCM patients have: headache, fatigue, cognitive issues. So if somebody has sleep apnea, then that needs to be taken care of much more aggressively than in general population. And that's what we are strongly recommending. And I don't want to go into detail, but our group is we recently got funded for that as well. We're doing some sophisticated studies in patients with cavernomas where we'll be putting them under sedation and giving them some carbon dioxide and oxygenation manipulation, and then looking at the MRI live at that time to see, can we see the leakage in the cavernomas change? Because, so it will be a very controlled, sophisticated study just to prove that. And the idea behind it was in New Mexico, we live on a higher altitude. Is that playing a role of why we have a higher disease burden? And that pretty much wraps it up. Sorry if I was over time. So, okay. Thank you.
Take a few questions. I think as far as an overrun, yours is kind of short, right?
Pretty short, yeah.
Okay. Aaron, did you want to? Sarah, I'm sorry, Sarah.
I guess with that last note on the sleep apnea, so is the I have a baby, I have a 6-month-old, so like she can't tell me
Right.
anything. But so is the recommendation here, for, to, like,
Test her.
sleep apnea?
Not her. So then it will become, so right now, again, we are in that phase where we're excited, but at the same time, we're not 100% sure whether it's playing a role. So we're doing it in adults. We do have some pediatric patients in our study right now who are teenagers. So we would like to continue to do it, there, get more data, and then see if you want to make recommendations in babies or neonates and infants.
But if there are other indications that sleep apnea might be at play, then
Absolutely, I think.
we would want to immediately.
Absolutely. We need to screen them, for snoring or daytime sleepiness and fatigue, and which are difficult to kind of pick up in babies.
Are you recommending spinal screening if you've identified one symptomatic spinal lesion, or are you just waiting to see if you get other symptoms?
So yes, if somebody has a diagnosis of CCM and they are reporting symptoms that are localizing to the spine, numbness, tingling in their arms, or weakness in the leg, which is not explained by the brain lesions, then the recommendation is to go ahead and do spinal MRIs. Typically, that's where the localization comes in. We can easily tell whether it's C-spine or T-spine, so we can localize it. But yes, if it's been done by a primary care physician and the access to a neurologist is hard, then yes, the spinal MRI needs to be done, the full access.
Okay, when we were talking about the flow being sluggish and how that can make us symptomatic, many people of us feel that our symptoms are sporadic, sometimes worse, sometimes not so bad. So do you know, does that have to do with the flow, or how would that correlate?
That's an excellent question. That's the question that I'm interested in answering as well. That's where the sophisticated study that I was talking about, where we want to do an under anesthesia study, is about. Right now, we don't know the answer to that. The idea, or my hypothesis, is that probably does play a role, that when that lesion has an even sluggish flow, that's when it becomes even more symptomatic, is what I feel like. And that's where the sleep apnea related studies and other oxygenation related studies are of interest for me, but we don't know the answer to that yet.
If you did know the answer, then what would the solution be?
Good point. So that's where the targeted therapy would come in. So by targeted therapy, it will be minimally invasive surgeries where we now have identified high-risk lesions that we don't want to take out because the surgeons feel like they're high risk. Then targeted therapies for those lesions that were misbehaving or that are symptomatic can be accomplished. So minimally invasive procedures mean going through the catheter close to that cavern oma and injecting the relevant drugs. If it's oxygen related or if it's carbon dioxide related, then giving the drugs that would improve the flow dynamics of that cavern oma. But that will be a totally new, innovative way of approaching CCM that as a group we have not even thought about or discussed as of now. So yes, it will open a totally new Pandora box.
Okay, so Audrey, then Kim, and then.
Sure.
So is it reasonable to assume that if you had a brainstem lesion bleed and it's likely to rebleed, that it's
So again, we typically refer to neurosurgery to answer these questions. But yes, if there is a lesion in the brainstem that bled, the risk of future bleed is high. There's no doubt about it. So then the next question comes in, does the neurosurgeon feel like this lesion can be taken out? And please feel free to jump in. I think it will be more relevant for you. Is it lower risk to pull it out? And then with all the data that we have based on where exactly the lesion and the bleed was, we can give you a percentage. This is a 15% chance of future bleeds in the next 5 years. And the risk of surgery is 3% or 6% complication. And the complications will be this. And then it's kind of a two-way decision. If the patients are okay with knowing that this is a disability risk that I will have from the surgery, and I want to get rid of this lesion because I know I have a 15% risk. So then it really depends on the patients. The other way of looking at it is if I have a bleed and I have some disability on the left side and it's a pretty significant disability and the neurosurgeons believe that they can take the lesion out and there's nothing more to lose, then yes, then the surgical aggressiveness is a little bit more, and then it can be offered. So there are multiple factors, and neurosurgeons, neurologists, data from the MRI and the functional MRI all needs to be incorporated, and then we update the patients and families, and as a team we decide what's the best way forward.
Okay, hold on. So Kim is doing a presentation this afternoon. She's a pulmonologist who's presenting on obstructive sleep apnea.
Wonderful.
Now ask your question.
Well, I have a pulmonology-related question because I work in ICU as well. So for patients that have CCM as well as DVT or pulmonary embolism, would you recommend to give them anticoagulation if they actually were to have a PE or DVT?
It's a controversial topic. Again, a topic that we don't know the true answer to. If the bleed is active and acute, then we like to hold and we like to go with the IV filter type of devices, right? But if the PE is huge, there's no other way, vascular surgery doesn't want to do a thrombectomy, and heparin or things like that have to be done, then most of the times we're okay. In my practice, I have about 25 patients with AFib or PE DVTs who have chronic cavernomas, multiple cavernomas, prior history of oozing in a few, and they're on anticoagulation, on Coumadin and DOACs and the newer anticoagulants. And I obviously watch them like a hawk and do MRIs frequently, and I haven't had any issues with any of them so far. So, that gives us reassurance. I have a few patients who do scuba diving and skydiving, and they go all across the world, and we used to say no to them when they have cavernomas, but they still did it, and they come and see me in my clinic, so I feel more comfortable now in allowing patients to fly or do those type of things. So a lot of the stuff is, we're learning from our patients as we go along, and we're feeling better and better with regards to how dangerous these CCMs can be. We feel like patients can take NSAIDs every now and then. Patients can be on blood thinners as long as there's no active oozing going on. Then they can be on Coumadin and things like that.
Would TPA be contraindicated in the asymptomatic patient?
Excellent question. I had a patient like that very recently.
Just tell them we're having a medical conversation, though, but tell them what
Right. So that's a wonderful question. There is officially, it's not contraindicated. So you can go ahead and give it, unlike an aneurysm where it is contraindicated. We didn't end up giving that to the patient because his symptoms were mild. And we kind of try to make the decision based on if I had CCM and I was in this situation, will I take the risk based on this? In cases where we don't have an answer, then we approach it this way.
it's a clot buster for anyone with the DVT or which is a
Right.
venous thrombosis or a pulmonary embolism. So
Yep. And just to answer your question quickly, so opioids is not the way to go. Botox would be, if you have bad headaches, Botox is what is recommended. There's many new drugs now that you only have to do an injection once a week. We're learning about them. We've been using them on our CCM patients for the last 4 or 5 months. We haven't had any issues. But then there are other drugs like lamotrigine and gabapentin and nortriptyline. Our favorite is nortriptyline, verapamil, and propranolol. We have shown good results so far in migraine headaches in CCM patients.
I'll take the Topamax, can't take.
Okay.
I already take that. She's got me on the Emgality shot,
Oh, they did. Okay, that's a good strategy actually.
but I won't take the opioid.
Okay. Sure. All right. Thank you.